I like that. I like that opening. I like the music, David. But anyway, welcome everyone to PerfWeb 80 Day 2, which is the number 10 Vanderbilt University Medical Center Faculty Forum. We just call it the Vanderbilt Faculty Forum. And so welcome to everyone. And I'd like to jump right in, kind of get moving on our opening remarks. To contact us, perfusioneducation.com, contact at perfusioneducation.com. If you have a question, you want to join our faculty, you want to start doing programs, have your own series on our platform, whatever the case may be, please reach out to us, or if you just want to tell us how great we are, whichever you prefer. Call-in number, if you want to reach out to us, is right there on the screen, 832-239-5358. And during the program, you'll see the scroll bar down at the bottom. You can see it now, actually, right there. And that is going to have all of our information about how to reach out to us, our social media platforms or sites, pages, what our contact info is, call-in number if you decide to call in at any time during the show. It's right there on the right-hand side. You can see it. And then I will move on from there to the MediWeb app. The app is becoming more and more popular. We've done 2 updates on it. The latest update has to do with patients who have refractory lung failure and whether you should choose VV or VA. So it's an algorithm that comes out of the ELSO book. It makes it convenient to select the most appropriate ECMO, VV, or VA in that situation and what you should do. But it has a lot of other stuff in it too. It makes doing your perfusion cases in the morning so much easier, and get all of your information that you're going to need for your chart and for planning your perfusion strategy for your case that day. And then, of course, we have the PerfWeb podcasts where you can listen to programs like this. You know, we're doing something new. I'll sort of talk about that a little bit moving forward with our Fireside chat sort of way of doing things here, which I think people will find interesting because, you know, you don't have the slides and all of the data and all of the, all the facts that come out from that, though those are important. But I think having opinions from people who are so experienced and know so much and are so deeply involved in this profession from a very high level, like Matt, who's going to be on with us here today, and then also like Deb and Ann. So real thought leaders, I think, bring a lot of value in just having opinions about things and being able to look at things from different perspectives. May help you out along the way. If you want to listen to our podcast, you can go to your favorite podcast streaming platform, Spotify, Podbean, or any of those other things that exist. And you can listen to us on your way to work or while you're driving somewhere, or just sitting around drinking some good quality alcohol, because sometimes you need that too for us. But anyway, let's move on to the introduction of Matt Warhoover, who is the program director of the VUMC. Hey, Matt. The VUMC perfusion program at Vanderbilt in Nashville, Tennessee. Also is are you acting now or past president of the Tennessee State Perfusion Society? I don't want to get that wrong.
Our state society's kind of been dormant for the last couple of years, but I am the last holding president.
So you're so technically then you are the current acting president.
That's correct.
Very good. Okay, well, we need to get that reestablished and do some great things with that. I know you've got, like me, a million projects going at one time, and it's a real effort to try to figure out where to put our attention. And of course, when you think you have everything aligned right, somebody comes along with a bowling ball and knocks down all the pins, and you got to start putting them all back up again. So I know that's a challenge. But anyway, welcome to the program today, and thank you for participating in this on a continuous basis. I think the VUMC Faculty Forum has been very popular, and we appreciate it very much. So welcome. So we're here today to talk about DCD as an up and coming methodology for increasing what will be the next sort of topic as we move forward. Organ availability, which is is just another topic. We could talk about this stuff, I'm sure, all day. And then we want to talk about not work-life balance, but work-life imbalance. And I think that our profession dictates that we have to be able to accept a tremendous amount of imbalance, but yet still be able to live and enjoy our lives and feel that we have a meaning in life other than just the sacrifice of going to work and taking care of patients who need us. And it's a very challenging thing to manage. So why don't we start off with DCD, donation after cardiac death, and maybe you can give us a quick update on where you guys are with that program and how you're looking to develop it further, and whether you see this advancing beyond the shores of the major medical centers like yours and becoming, used in more places. Like, I don't even know how many places actually do this, how many programs like this exist in the United States or even on a worldwide level. So let me let you just go ahead and tell us what you can, and I'll try to ask you questions for things that maybe I haven't really quite understood or elucidated from your comments.
Sure. And so, DCDs have been used for 30 or 40 years when it comes to liver and kidney organ transplants. They were the first organs to be transplanted like that. And to be quite honest, internationally, it came through the last probably 5 to 7 years, and then most recently, I think there's probably close to a dozen programs attempting to do this now for cardiac.
About a dozen,
so,
you say? So about 12 programs looking to do DCD for cardiac surgery, for heart transplantation.
Yep. And the real issue, behind it is there's just a large mismatch of organs to available to people that need organs. And so, traditionally these organs, wouldn't be considered, at least the hearts wouldn't be considered to be, used and be useful. But, we're beyond the proven model point that we know that, a good percentage, upwards of 80 or 90% of people that are able to donate after cardiac death that are under 40, we utilize 80 to 90% of those hearts.
Wow. But there's a process, right? You have to reanimate these hearts because you're allowing
correct.
The heart, I'm assuming it's from a hypoxic. It's basically a hypoxic arrest, so they become very. Is that the process? You have an ischemic period. The heart gives out, and then you have to, because now you have technically a global myocardial ischemic event take place, and you have to reanimate this heart. This isn't like post-cardiotomy syndrome, reperfusion injury, from a difficult case that had, diffuse coronary disease, and you did a mitral valve, you had ischemic MR, and you had a long pump run, long cross clamp time, et cetera, et cetera, et cetera. These are hearts that are healthy otherwise, with no coronary, no atherosclerotic heart disease, and you have to allow the patient heart to stop from death, where they're, I guess, not on the ventilator, they're not breathing, they become hypoxic, and the heart finally gives out. And now you have to resuscitate that heart and get it to where it's functioning normally again, which I find a fascinating process.
Yes, you described exactly correct. We usually can get on the I'll call it an ECLS circuit, because that's really what it is. we're able to get on the ECLS circuit with the head vessels clamped, and that's very important. That you are reconditioning all the organs from the carotids down. So there is no blood flow that is that goes to the brain. That's the idea about the DCD NRP, normal regional perfusion. That's what they call it. And so they essentially do a really quick sternotomy. There's usually, so the patient does become ischemic from hypoxia, and you can see the patient will Brady down, then usually go into a PEA arrest, and then they're declared. And then depending on institution, it's between a 2 and a 5 minute standoff period from that first declaration. The pronouncing physician will check at 2 or 5 minutes, and then there's a death certificate that's issued at that time. And then the abdominal team, if they're taking abdominal organs, which a good number of the times they are, and then our cardiac team, they do a quick sternotomy, pericardium, clamp the head vessels. We cannulate with a large dual stage venous cannula. We drain the heart immediately because the heart is distended; it's not beating, and it looks as though it's very swollen. It's not beating, and so the very first thing we do is to try to drain the heart to lower the wall tension, and to actually minimize whatever energy is being utilized, because there is no oxygenation going through. It is in an anaerobic state for sure. Drain the heart, decompress it, and then the surgeon, this is probably the most difficult portion of it, they're trying to quickly cannulate without purse strings into a flaccid aorta. And so it takes a couple sets of hands to get that to put tension pulling up on a flaccid aorta while trying to cannulate the aorta. We go on slow to make sure that we don't delaminate or cause an aortic dissection. Get the aorta filled back up. We get a good pressure, and then one person holds the aortic cannula in while the purse strings are put around it after we're on. Once the purse strings in, we'll get up to a full flow index of about 3. We try to hyper perfuse the patient to try to minimize any lasting ischemia. We really want to get the perfusate turned back around into an alkalytic standpoint. We usually have a bunch of different pharmacological interventions, whether it be bicarb. Once we get a heart rate back, usually within the first 5 or 10 minutes, the heart rate will come back naturally. I'll have to shock it, but these are, like you said, Joe, they're really, really healthy hearts. And so there's really, if we do have any kind of arrhythmias, that's kind of a red flag for us that we need to be looking at other things, that maybe this isn't because that's just not been our experience, that it doesn't come back into a normal sinus rhythm once you get back on the ECLS machine.
Yeah, that's just so fascinating to me, and it makes me I find it odd. It's hard for me because I'll ask a question, and I think this is perhaps it's going to be a provocative question, but has anybody ever in the standoff period that you're aware of miraculously recovered?
Well, we haven't had that them actually come back as far as a rhythm, but they have the reason that they're not considered a brain death donor is because one of the 4 tests that they run, depending on how you look at it, they either passed one of those 4 tests or they did not fail all 4 of the tests to declare them brain dead. So we have had people that they'll Brady down, and it looks like they're getting ready to rest, and all of a sudden they'll take a whether it's voluntary or involuntary, no one knows, but they'll take a huge breath. And then their SATs, were, in the teens, all of a sudden the SATs go up to 60. And then, your heart rate's in the 30s, and all of a sudden the heart rate will go back up to 50. So there is, no one's actually come back after that first declaration, but there is some significant waiting period, if you will, for these people to actually pass. We've waited up to 2 hours. I think an hour and 57 minutes is our longest wait.
Yeah, yeah, that's a long time. That has to be extremely just very almost troubling. And and you did answer my question, but I want to be a little more, I think, even more provocative than that question. Is anyone who ends up down there who is going to be donating these organs? So, two questions. Is there any risk at all that any of these people have any awareness of anything that's going on at that time? That's the first question.
Yeah, I will say, I think there, I'm not a expert on neurology, and most of the times it's a head injury, or it's a chronic state that the patient, they had a chronic disability that ended up with a hemorrhagic stroke. What I will say is that they are under the care of the hospital that they're currently in, and I think that's one of the paramount buffers, if you will, that we in the beginning we would not consider doing a DCD donation intra hospital. A Vanderbilt patient couldn't donate DCD organs for a Vanderbilt program to get the recipient, because ultimately, if you step back away from that, you're looking at it, there's a conflict of interest. You have a responsibility and a duty to look out after the best of your patients, and on the other side, you're looking for the best interest of a patient that needs an organ, right? And so you're in a little bit of a juxtaposition, and so until most recently, until there was more people, more institutions getting on board with this, and these talks happen at a much higher level, but there is a little bit of a conflict of interest. And so I think as long as you start with those boundaries, I think everybody is doing their job. You've got someone that's taking care of a patient until they don't become a patient any longer, and then you've got a team that's trying to look after their patient that isn't necessarily at that location, but they're looking out for the best interests of their patient. And so prompt getting, speed, getting on safely, and trying to recondition an organ that you can actually utilize and help another patient.
Mm-hmm. And that's that's a very good answer. That's so much to think about. One of our viewers said it's exciting and petrifying at the same time. And that's how I feel. They echoed my feelings very well. So another question, if I may, and again, I know that this may be a difficult conversation, but is anyone going to make it down to the room, across wherever the room is, the operating room where you're going to be doing this? Is anyone leaving that room alive under any circumstances?
Yes. Yep. So, just like there's a 2 or 5 minute standoff period for that institution, there's also a period of once they withdraw care, whether the anesthesiologist or the nurse extubates the patient or takes them off their trach. There is a time frame at that particular institution. Sometimes it's an hour, sometimes it's 90 minutes, sometimes it's 2 hours. But yes, and that's what I said, the 80 to 90% recovery rate of these organs. There's generally 3 different ways that we don't leave with a useful organ. One, the patient doesn't expire, and that happens. They come down, they withdraw care, they take them off the vent, and they spontaneously breathe, and they don't expire. And so then they, unfortunately for the I would say 50 to 60% of the times the families are in the operating room when their loved one is being withdrawn. And so it's really tough for the family to sit there and then they say, okay, well, this didn't happen. And so then they roll, they take them back out of the operating room and the family goes with their loved one back to the ICU. And, I don't know of anybody that's actually recovered that's been on there. I haven't heard any of that. From my understanding is they just expired, hours or days later. Mm-hmm. But that's one way we don't get an organ. Second way we don't get an organ is during the procurement. If there's a complication, whether we've had a right ventricle puncture going in, we've had an aortic dissection on cannulating, trying to get on the ECLS machine. Whatever the complication is, we've taken the heart out. And remember, these patients were they were patients. So they're not set up to do the diagnostic work that a regular brain dead donor is. And so, you do the reconditioning of the organ, you go to cut it out, and you get on the back table and you find out that they've got a bicuspid aortic valve.
Ah. Yeah.
And so you don't know that because these patients don't get echoes. They don't get cath because they are patients. And so that isn't fundamentally paramount in their care. And so after the fact, the surgeon takes it, cuts the heart out, puts it on the back table to try to prepare it for transport, and the patient's got a bicuspid aortic valve, or it's got a thrombus, on the mitral valve, unbeknownst, to anybody. And so we just walk away. A lot of people, they've had they can visualize with I guess tactily, they can visualize a atherosclerosis in the LAD. Early onset, people in their late 30s, mid 30s that actually have disease process to their heart. We've seen that. So there is a small percentage of when everything even goes, perfect, you get the heart to the back table and it's a no-go.
Mm-hmm. Yeah, there was, speaking of, heart disease, during the Vietnam era, they were finding doing the postmortems on some of the killed soldiers, 19 and 20-year-olds with actual lesions in their coronary arteries. So there are some people that it starts very early on, but I find that do you guys do a bedside echo, a TEE, to look to see if, you probably wouldn't be able to diagnose a bicuspid aortic valve, but you might be with the TEE. You should at least be able to detect a gradient, or to observe the mitral to see if there's anything there prior to bringing the entire team out there, because I'm assuming that's still a very big expense. There's still a cost associated with that part of it. But, to do an advance party to evaluate the patient to make sure there's nothing that would absolutely exclude the patient.
Yeah, from what I understand, now if it's within the scope of them being treated for whatever illness or, disease process that they have or whatever event occurred, then, it's just that the outside hospital, Vanderbilt, as is my example, Vanderbilt can't request any medical treatment or any additional testing on that patient because they are still the hospital that there is still under taking care of them as a patient, not as a donor, and that's where they don't ever become a donor until they actually pass.
I
and
understand.
So that's the kind of the tricky part is that we can't request any of that stuff because it's still a patient.
Yeah. So there's tremendous amount of protocol and ethical, and I mean, I imagine it has some ethical dilemma to it. I don't know. I mean, these patients, I mean, they're not planning on walking out of that hospital. I mean, they wouldn't be at this point, I don't think. I mean, maybe somebody has. I can't imagine that's possible. But without getting into that, I guess I had a different question, and I need to try to keep myself sort of somewhat directed, if I may. I've always understood that there's a tremendous amount of hormonal damage that can occur to a heart if you were to just clamp the brain out, that there's going to be a lot. Now, I don't know that exact process. Maybe you can, explain it a little bit better. But is that accurate? And what is it that happens?
Well, I'm not an expert on the on hormonal pituitary and all what gets excreted at what rates, but I will tell you this, that and this is from the transmedics people, that they found it very important when you isolate the heart in the OCS, is that for DCDs only, not for the normal donation, but for DCDs, they infuse levothyroxine, and so I believe that's that's a hormone that is secreted from your brain, and so that we do use that in our prime, and so that is an important hormonal, if you will, component of preserving the organs, at least for the heart. Now we are doing some studies on the lungs. We're not having as good a success in taking lungs with the DCD process, and we don't know why yet. And so there's a gambit of different theories out there, and one of those is, are we sacrificing by putting levothyroxine and other components of our prime? Is that being harmful, or are we choosing a heart over a lung? And is there a balance that we can develop a prime that is both preservative to the lungs and the heart? Because we have yet to be able to procure a set of lungs, or actually even a single lung, with the DCD heart procurement, and we don't know why yet.
That's interesting. I wonder, and I'm curious. Do you see the on the lungs? Is it in just massive increase in lung water, or what is it? What happens to the lungs that you're seeing that makes them not suitable for transplant? What's the process that you see?
Well, in typical lung transplantation, you run PO2s on the pulmonary artery. You pull what's going in, and then you look at what on the pulmonary veins, what the oxygenation is. That you can and see what kind of, quote, oxygenation and respiration that the lungs are actually doing. And we just find that the lung function is just really poor, and there shouldn't be a real reason for it. Now, I have my own theory. I think that when a patient expires, you're not pulling air in, and most of the time they're always on a ventilator, so there's positive pressure ventilation going on. And when you pull that away and withdraw care, the lung, they're compliant. It's almost like that they're not seeing that positive pressure, and then as you're braiding down, you've got a right heart that's pushing volume through, and the lungs aren't expanding and they're not contracting because they're not taking breaths. I just think that they really get boggy that way, and we have seen that the worse the lungs are, the worse the right heart is, even after we come to recondition the lungs, or recondition the organs. And so there's got to be I think there's got to be a correlation with how bad the lungs are, um, and I think it reflects in what your right heart dysfunction looks like, because I think I think the right heart is actually trying to pump, against essentially a wall, if you
Yes.
will.
Yes. Yes. Well, I mean, it dilates, and I'm sure that, of course, hormonally, you could get, I guess, a a massive pulmonary hypertension, vasoconstriction. I just simply don't know. I'd be curious to know what the lungs look like histologically, and whether there's a big influx of leukocytes, or what actually happens to the lungs when all of this goes on. So there was a question, and I think I know the answer, but I just want to confirm it, and just have you answer it. When you cannulate, you're going on, are you going on ECMO, or are you going on full cardiopulmonary bypass with a reservoir so that you can empty the heart completely? How are you doing that? Or is it a hybrid ECMO with a reservoir so that you can empty the heart?
Yeah, that's exactly right. What you talked about at the description. We essentially are taking an ECLS circuit, a closed system, ECMO, centripetal head with an oxygenator with just an AV loop, and then we are cutting in a standard cardiotomy reservoir into the circuit so we can drain the patient. It's twofold. One, we can drain them right away because the patient is not the reservoir. You want to decompress. But also we have to, have a way to actually add volume to, and because on traditional organ donation, there's no, as people are dissecting out to take organs, they have a constant heartbeat and a blood pressure. The patient's considered brain dead. So as they're dissecting, they actually see bleeders as they're going in, and they'll bovie or cauterize them going in. When the very first minutes of opening the chest and opening the belly to go on, there's no blood pressure. And so, and there's an impetus to get on the ECLS machine to get a blood pressure back to recover the organs. And so, by the time everything is in the first 12 or 15 minutes, it's kind of a little bit of a organized chaos. There's a large amount of blood that is on the floor because nothing has been bovied, because there was nothing bleeding on the initial, when you're going in. As soon as you get that blood pressure back, we're trying to float an index of 3, everything's bleeding. And so we have 4 units of blood cross-matched in the room from the donating hospital. And so that's part of our protocol. But yeah, we have to have an open reservoir.
Wow. Yeah, that sounds, man, I'll tell you what. So, how many of these cases are done in a year in your institution, and then nationally, we'll say, just here in the United States, unless you know the worldwide numbers?
No, I don't have the worldwide numbers. I know in the last 14 months, we've done 50. We're up to, I think, up to 62 or 63.
Wow.
And I could be off by a couple, but we've done well over 60 in the last 14 months. And nationally, there was only 2 or 3 institutions probably a year ago that were doing it, but I'm getting phone calls every day from places in Florida, in Wisconsin, Maryland, North Carolina, Denver. It's starting to catch on. The difficulty is, I hate to say it, shortage. Perfusionists don't grow on trees, as you know.
Very
personally.
well. Very well.
And so the real issue is that the margin of your increase in cases by putting this program, offering this program at your institution, it is a lot of work, and it's a lot of work in a small amount of time, but the bandwidth, by adding this program on, you don't really get to add an FTE because the volume of work isn't there. But it does provide an amplitude that you can't really account for in your staffing model, because this is something that you're taking a minimum of one. We take two, but people are talking about doing it with one perfusionist and a perfusion assistant, or the perfusionist and the procurement preservationalist. You're taking that person out of your schedule for 10 to 12 hours. And
Wow.
right now, I don't know, I know how, you have a private group. You don't have the luxury of having a normal schedule, and then having normal vacation time off, and then all of a sudden something that is not within your scope of normal practice, all of a sudden you lose somebody for 12 hours. I mean, it's a significant obstacle to overcome.
Right, and these are planned, but in an unplanned way. You can't just say, okay, we can be there in 2 days. It happens now. I'm assuming that is the way it works. Had a question. I think I know the answer to this, but I'll let you answer it. And it's from one of our online audience. We get a lot of activity online today, which I appreciate. I'm glad. Why are you running an index of 3? I think I know the answer, but you answer it.
Well, like I said, we try to run an index of 3. What we're trying to do is we're trying to overcome the lactate. We're trying to wash out the lactate. We're trying to get as much flow as possible to quickly offset the ischemic period. Some of these patients, were extubated. Like I said, we've done as long as an hour and 57 minutes. And then, we were 3 minutes away from having to, go back up to the ICU, and the patient expired. So we were able to get on. But, that patient was in, some sort of state of decline and or death for an hour and 57 minutes. What we're trying to do is we're trying to turn that acidosis around as fast as possible, because we only have between 45 minutes and an hour to actually turn that around. That's our limiting factor because of 2 reasons. One, it's just a time frame that you're in a hosting hospital. You're taking up a hospital suite in their OR. If you in all reality, if there was no limits, of course you'd want to condition the patient over a set of hours, but you don't have that luxury. And the other reason why you don't have that luxury is, like I talked about before, the actual bleeding. You're working with another team, usually the abdominal team, that may or may not be as vigilant and not quite understanding what the hemostasis, what the priority is with that. And so we continue to lose volume, and then we only have 4 units of blood, and you've already got someone that's had some sort of a catastrophic or traumatic injury, so their crit already starts usually around 25 or 27 anyway. If you look at any of the medical ICUs or surgical or trauma ICU data, most people aren't getting transfused with hemoglobins. The eight is fine. They don't transfuse until they hit 7, and so you got these patients that are already starting with low crits. Then we dilute them down with 800 of prime in our circuit. And then with the bleeding going on, you just run out of volume. 45 minutes to an hour is all you have.
You probably aren't able to do this, but there's another really good question, and I'm assuming that because of what you're describing, it's not feasible. But do you hemofilter or Z-buff these patients to try and manage this acidosis, this acid-base imbalance, electrolyte imbalance, lactate clearance, all of those things where Z-buff, if you're using the right fluid vis-a-vis a bicarb-based fluid versus, let's say, isolite or plasmolite or normal saline, which I think would be disastrous in this case. But do you have time or volume to do that, or is it just too insane and busy just managing what you're doing?
Well, so we have used a hemoconcentrator on a couple patients where we keep one with us. traditionally we don't have the amount of volume to actually do a pure hemoconcentration, but we have talked about Z buffing. That may be the next more or less change in protocol, that we may start doing that. I think without, once again, we're packing all our equipment up, and we're taking it with us. So having there has to be at least one Neptune or vacuum source, and we try to get two, because there's a lot of teams in there. When you get an abdominal team, the chest team, and there's a lot of suction going on, and a lot of suction going in the wrong place, because I'd like to have all the blood back into my cardiotomy. So we do use vacuum assist and we use suckers, and we control the suckers with the little the little cricket clamps that you have, and we turn them on and off as our surgeons are needing them, to try to get that shed blood back in. So there are some components that some ways that we try to prolong the amount of volume that we have for the length of time. But I don't know what kind of it's kind of the first 10 or 12 minutes are very tenuous. So Z buffing at that point probably isn't really doable, to be quite honest. And then that leaves you with about 30 to 45 minutes of Z buffing without, I think you could make a dent in it, but I don't think you're going to get very far. I think once again, I think that goes back to our pediatric colleagues. Why do you muff at the end of a case? Well, you muff at the end of the case for pediatrics because it works, because you can go through 2 or 3 blood volumes of that patient in a short amount of time. Trying to do that on an adult, I'm not sure that you're going to get the amount of Z buff in that amount of time that's going to be incrementally advantageous for you.
Yeah, I can see that. I could definitely see that. I wouldn't think you'd be able to. Another really good question from John Ingram is, when you go back on pump, because you've already been ischemic, and do you go on with a low FiO2 and then turn that up over time after establishing flow, or do you reoxygenate? What's your concern about reperfusion injury of the heart and any kind of those reactive oxygen species, oxygen radicals, all that stuff?
Yeah, so we use Mucomist in our prime, and we use mannitol. So we are concerned a little bit about the oxygen free radicals, but once again, we don't take a blender with us. We use the wall oxygen from the port of the anesthesia machine, and we're just using suction tubing from the oxygen port, and we're directly going into our oxygenator. So we use 100% oxygen, and we go on at 10 liters of sweep a minute. That's what our standard is. And probably around the second or third blood gas, we try to run blood gases every 12 minutes. By our second or third, we're most of the time, depending on how long the patient took to expire, that they were in that declining phase, we're able to come down to 6 or 8 on the sweep, probably in the 36th to 40th minute. But if the patient took a long time to expire, we're at 10 a sweep the entire time. That's how acidotic these patients are.
Mm-hmm. Yeah, so that's amazing. So you're really, of course, you're not worried about cerebral perfusion. So you turn the sweep up, you try to blow off all of the CO2 just to get your pH up is why you're doing it. So you'll be respiratorily alkalotic, because you just want to get a pH that's going to be somewhat normal. Because I'm imagining that you want the blood pressure to go up as well, and when you're severely acidotic, it's really hard to get any vasoactive substances to work. You just can't get any really good vascular tone. That's at least been my experience.
Yeah, and that's the other reason why we try to flow at an index of 3. Everything is so dilated, and so and you will see that your tone, you talked about it exactly right, Joe. Your tone actually comes back as soon as your pH. Our pH is usually in the unreadable. It's below 7. We prime with 100 milliequivalents of bicarb in our. That's our prime. We're sweeping at 10 liters a minute for at least 30 minutes, and we do have our first lactate is somewhere usually between 7 and 10. And then what we do like to see is we like to see that our second lactate is at least in the same single digit. It doesn't necessarily have to be going down, but we definitely don't want it to go up more than one digit. And then by our third blood gas, we want to see that it's at least lower than our first. And so that it never gets below 7 or 6 generally, but it's just trending in the right direction.
So then after you've done all of this, you harvest the organ. It goes into the device, the heart in the box. You could talk about that company, that process. And then you continue to manage that organ beating for your trip back home. So you have to take the ECMO pump you brought, the disposables you're going to leave there and get rid of, but I'm assuming you have to bring backups. And then you take the patient with no, not the patient, you bring just the organ. So you don't bring the patient back with you, but you bring the organ in a box and go back to the fixed wing, helicopter, and whatever process you're going to use. I'm assuming it's going to be fixed wing because you're going to have a long distance travel. And then go back and take it and you're working on it continuously through that process till you get back to the hospital. Then I'm assuming, has to be examined again to make sure it's appropriate. So you don't take when you're coming back, do they bring the recipient into the OR? They're certainly not going to remove their organ at that point in time. What's the time frame from getting back to the hospital and the process there before you say we're a go for transplant?
So we have two different things. The heart in the box is the OCS device, and within that device, you can do DCD or you can do brain death donor. And primarily, what you're doing is you're conditioning that organ on the way back. We use that device exclusively for two reasons. If our flight time is greater than 2 hours and 15 minutes, because the cold ischemic time, just for travel, you can add about an hour on wherever you're at going to get it, and then once you get back to Nashville, that's a total of an hour. Then you've got 2 hours and 15 minutes of actual flight time. You're at 3 hours and 15 minutes, and then an hour to get the organ in. You're over 4 hours right there. So that is our limits, that if we're longer than 2 hours and 15 minutes in flight time, we use the OCS because we can have that organ continuously beating all the way there. And you can use it as a DCD donation or a brain death donation. What we've been talking about this morning, what we do is we recondition all the organs from the head down through the ECLS pump, and then at that 45-minute to an hour mark, it turns into a regular donation where we cross clamp, give cold preservation solution, cut it out, put it in an ice bath, surrounded by in a cooler, and then we run with it. So to your point, once we come off the ECLS, we clamp just like we would coming off the heart-lung machine. We clamp at the 45-minute mark, and we take a video. And with no pressors, there's nothing going. This is just, you want to see what the baseline is for this organ. We take a video and live stream it with the implanting surgeon. And at that point, they determine whether they want to proceed with the patient recipient. The patient recipient is always in the room. They're not put to sleep yet, but they're ready to go. And then once we see that organ, the implanting surgeon sees the organ, he approves it visually. They go off to sleep. Once we take that organ in the next 15 minutes and take it to the back table, and the procuring surgeon examines it to make sure that it doesn't have a bicuspid aortic valve, to make sure it doesn't have a thrombus, to make sure it doesn't have a calcified lesion. Once the visual inspection has been done, there's another phone call that goes back and says, we've got the organ out, everything looks good, you can proceed. And then that's when the incision starts on the recipient.
Mm-hmm. Wow.
And then we have our that hour window of travel time on the ground, usually half an hour where we're at, half an hour back in Nashville, and then whatever flight time we have, to get the it really doesn't change from a regular donation once the video is made.
So
It's just like,
and I think that's very interesting, but it brings up an interesting question for me. And don't let me forget, I have to ask you a question from the web, so don't let me forget to do that. Somebody remind me. But if you get it, you video it, the implanting surgeon likes it, you explant it, you take it to the back table, you examine it, it looks good, there's no issues, another call gets made, they can proceed, you throw it in your box with the ice solution and so forth, and you on your way to the airport, and they're starting, because now your clock is running really fast, okay? You got to get back, 2-hour, 15-minute flight, if that's how long it's going to be, and then you have to get it implanted in 45 minutes from the time you arrive, but if that's going to be the actual, if you're 4 hours worth of the time frame, if you explant the heart from the recipient and for some reason you don't make it, which could happen, likelihood I understand is very slim, but do you guys make a conscious decision to get this organ out and the area prepared for the implant so that when you get there, you have that extra time to get the organ reimplanted and reperfused, and just take that risk? Or do you really wait until the organ is in the room before they remove the heart that is going to be replaced?
That's a great question, Joe. And I think that's institution, but we typically never go on pump, never physically go on pump until the plane has landed back at BNA. So and the organ is the recipient's native organ is never taken out until the heart is physically in the room.
Wow.
And so,
okay, that's what I would think.
On bypass. Yeah, we may be on bypass, but there is no removal of the native heart until the other heart is in the room. Now,
Understood.
You're on full bypass, everything's open and ready to go. But I think that's institution to institution. What the comfortability and what the how things. There's some organs that are dropped in on a helipad.
Mm-hmm. Well, it has happened. It happened in New Mexico with Dr. Hoyt. I don't know if you know this story or not, but they took off from the West Mesa coming to Albuquerque with an organ, and they had the patient. They said, we're on our way, and they had the patient in the operating room, and they took out the organ, the heart, and the Dr. Hoyt and the heart and his assistant, they hit the side of the mountain and they all perished. And now you have a patient on bypass with no heart in them at all, and they scrambled. They actually were able to find another organ, and that patient ultimately survived. But think about the stress associated with that. That was a remarkable story when I heard about that. That was some years ago. It was in the late 90s is when that happened. I think you could look it up. His name was Dr. Hoyt. I don't remember his first name, but it was at Albuquerque Presbyterian Hospital in Albuquerque, New Mexico. It was an absolutely riveting story. We had a question about CytoSorb. When you get on pump, do you see any potential value of having a CytoSorb filter integrated in your extracorporeal, your ECLS system. So when you, even though you'll have these volume issues, but you won't be technically ultrafiltrating with CytoSorb. It's more of a flow right through it adsorption. I'm assuming you're familiar with it. So do you see any value in that? Because I would think there would be massive inflammatory mediators that are screaming through these patients.
Yeah, and I think there is value of that. Like I said, I think keep it simple, and I, to your point, you know, we talked about why the lungs may be not working as well. You know, that is definitely something we probably should consider.
Yeah, that would be interesting. Okay, so we have two other topics to cover at 9 minutes. One, organ availability. This probably isn't going to take very long. And we'll talk specifically about hearts, if that's okay. We could talk about lungs too, but hearts. This process exists because there simply are not enough organs in whole, but then also finding organs that are a match for any one person may not be in the geographical zone that's suitable for traditional harvest reimplantation. It's too far away, and that's why all of this is coming to be. What's the real just sort of stress associated of the system stress associated with these organ limitations that exist? Like, what's the how many potential hearts do you need, recipients that need hearts, and how many hearts are available? What's that ratio?
You know, I don't know the exact numbers of where they're at. I just know that the ratio is for every one organ that's available, there's 10 or 20 people that are needing one.
Wow.
When it comes to hearts, and so essentially, what we're not going to be able to change. If you want to say that the patients are the denominator, you're not going to be able to change that. You know, not for a lot more advanced when it comes to stem cell and maybe you know, a substructure of you know, creating a new heart, if you will, or implanting, you know, some recovery, some sort of recovery for the native heart. We're not there yet, so you're not going to be able to change the denominator. This, you know, whether DCD changes the numerator, the OCS changes the numerator, because now you're able to, like you said, geographically, if you're sitting in Maryland and your exact donor, you know, that is perfect, is in Seattle, well, it's just not doable without OCS. And so, and you know, you can say, well, you know, we can wait and we'll find another heart. But you know, with HLA testing and this matching, they have it down to, you know, a pretty good science on who really needs that, who is best suited for that heart. And so, you know, with matching and things of that nature, you're getting years added to those organs, right? I mean, if you have an organ that really doesn't match, you know, with the HLA, with the size, you know, that's a significant impact on the length of your, you know, your length of organ. So I think that's really the next generation of things, is that there's going to be a national, and I see it in, you know, an international UNOS, if you will, and being able to go, hey, we have this heart in Puerto Rico, or we have this heart in Hawaii that matches this person in Denver. And I think, you know, I think that's where the future lies, is that they get it genetically, you know, down to a science where they go, we know exactly what, you know, what organ is going to be best for you, and it's located, you know, 7-hour flight from here. And but we're going to, that's where OCS, and I think that's where some of these pioneers in this organ preservation industry, that's where it's going.
So in the few minutes we have left, how are we going to do all of this if we don't have a fairly substantial percentage of perfusionists that want to, because I calculated just very quickly, your institution alone requires, if you say it's a 12-hour day, which it seems reasonable, probably it may be more than that, it's 600 hours a year dedicated to just this one thing, which is a large percentage of the 2,080 hours that is a full-time job. That's just for those 50 cases, 50 days, right? That's a lot. That's a big chunk. And you're not going to just do that for a living. There's going to be a lot more to it than that. So, as we continue to deal with our profession, evolving and new schools. And I know you're, of course, the acting director of the Vanderbilt University Perfusion School. Anybody interested in going to school should really be talking to you because you've got such an incredible program and you do so many incredible things. What you learn there will last. It will give you an edge in your career moving forward. But how do we do that if we don't have people that want to live this lifestyle, number one, and number two, how do we attract people from a compensation perspective and also from an opportunity for the same kind of lifestyle and notoriety that other people that have to spend that much time, different people in the process, the medical process. Do we need to look at how we're doing all of this and whether perfusion should become more of a market that is cardiac surgeon, anesthesiologist, cardiologist, sort of patterned after, versus the model that we currently use in order to be able to attract people that want to, essentially you're sacrificing your life for this. And what's the reward other than feeling accomplished, which is important, but I don't know that that's really going to attract the people that we need.
Well, I can, I agree with you on all those fronts. What I will say is I think it's a very similar problem that we have in some of the smaller, or I want to say rural. Rural is maybe not the right word, but outside of your major cities, there's perfusion going on. I mean, and good perfusion. I mean, the programs wouldn't be open without good surgeons, good anesthesiologists, and good perfusionists in places regionally where I can just talk about the smaller hospitals and the smaller cities that have good hospital programs, but towns and Carbondale and Paducah, Kentucky, and Jackson, Tennessee, and you don't have to be the Nashvilles or the Houstons or the Chattanoogas or Chicago or St. Louis. You're talking about smaller cities that do great work, and I think this is no different. How did we get over a period of time that you were doing 20 years ago those programs, or 30 years ago those programs either didn't exist, or if they did, they were in their infancy, right? So most cardiac surgery was done in big cities, and as population spreads out and there was a need, people met those needs. And so I think this is very similar, where we're at an infant stage of this new type of technology, this new type of service. And I think dedicated perfusionists will step up, and they're going to your only point, compensation will probably stay. I don't think you're going to get rewarded more for doing something like this. I think compensation is going to be flat. The hospitals are are just going to say, this is part of your job. But what I will say is I think the demand of the new need will be met by perfusion, because quite frankly, it always has been. Wherever the need is, there's dedicated perfusionists, there's pioneers that go out and do it, and then people follow suit because they go, I am proud of what I do. It is rewarding, and
Matt,
also
it's why I love you, dude. It is why you love me. Just philosophically, we are cut from the exact same cloth. I'm just younger and better looking than you, but that's the only difference between us. So, so with that said, what do you think of this forum? What of this format? This kind of, fireside chat, roundtable, whatever you want to call it, discussion about these topics versus the planned presentation, kind of going through data. What do you think of this?
Yeah, I think you get a lot. You're there hosting, but I think you get a lot of live interest. You said we've got a lot of questions, or it seems like there's a lot more questions this morning on the web than typical. So I think it's at least it sparks people's attention. It's more of a conversation, right? It's more of a discussion. If people want, I think with the internet, and with the databases that are available for all the journals and things like, if people are wanting hard science, I think it's available for nearly anybody. Certainly at a certain price you can get it. But I think this is what is invaluable, and I don't think you can, if you're looking for this, I don't think this type of format is really able to be easily obtained, like the hard science that's in journal articles and editorials and poster presentations of that nature.
Yeah,
So I think this is really invaluable.
I think so too, and the interactivity of it and getting asked questions from online, it opens it up to so many different people and thoughts and questions, and helps us, you to, hey, that's a really interesting idea, and something may spark, your thoughts, and that you take that back to your program. I think that's the whole point. We all learn from each other, and I enjoyed this format a lot. I want to do more of it.
Yeah.
Last real quick question, and I'm assuming again the answer is yes, but I want to make sure I ask it. Does the reconditioning organs, that process of going on ECLS, help to improve post-transplant outcomes? Of course, I would think yes, but in a word.
Yeah, it's funny you say that. We there's really no set data point on hearts yet. We haven't done enough, but it's funny you say that the implanting liver surgeons and they once they start to implant the organ back at the location, the organ starts making bile intraoperatively.
Wow.
And they don't see that quite often. And almost all on these reconditioned organs, they've seen with the DCD NRP that we're doing with the regional reconditioning of the organ, they're seeing the livers start to produce bile intraoperatively while they're implanting it in the recipient, and that's
even more so than you would see during a, let's say, brain dead donation of the liver.
Yes.
Which you don't see
Yes.
that often in those.
Correct. Yep.
Very interesting.
And so that's really the only anecdotal takeaway that that we've seen. But the liver teams have really liked their organs that they're getting from this. They've made comment.
Very good. Well, it's been a pleasure, Matt. Thank you so much for another, for dedicating your time to this. I know you've got a lot of stuff going on, and you carve out some bandwidth for us, and I just appreciate it so very much. We will see each other again very soon, I'm sure. And we'll talk about what we're going to be doing, maybe moving forward from here. But we all, on behalf of everyone, appreciate you finding the time to do this with us. We learn a lot, and we just appreciate you. Tomorrow, I'm going to actually be remote. no one is actually physically going to be in the studio tomorrow. Everything is going to be remote because we are really busy and I have to take a trip and do something. So we're going to be doing a similar format. And we're going to be talking tomorrow about, what's the program on tomorrow? Oh, yeah, disparities in ECMO outcomes. Matt, and if you want to join in, you're welcome to. It's all remote. Tomorrow at 3. And I'm very struck by reading a variety of articles and finding some that say that for COVID ECMO, they had 90% survival, some 50%, some 60%, some 40%. I've seen our own experience, which is less than 20%. And how can it be such a wide variation in actual outcomes? Is it selection? Is it how we're doing it? What are they doing that's better than what we're doing? Or does it really just come down to luck? I don't know. I really can't tell you I don't know the answer to it, but I do know that I've been very struck by the wide variation in reported outcomes with COVID ECMO and then my own experience. So if you want to join tomorrow, would love to have you. I certainly understand if you can't. It's tomorrow at 3 o'clock, 3 to 4. It's going to be myself and Tammy. And if you do join, it'll be you or anybody else that may want to join is always welcome because I think it would be a very interesting conversation.
Yep.
Okay. Thank you, Matt. Be safe. Good seeing you. Everybody else, we'll see you tomorrow at 3 o'clock. And Matt, lovely office you have there. I really enjoy it. I've been jealous ever since you came on because it looks very comfortable. I really like that office. I'm assuming it's a home office, which would be even better if it is. If that's your office at Vanderbilt, I'm quitting and I'm coming to work over there.
It's safe to say, that's my daughter's desk. This is our home office. Yes.
Very good. Excellent. Sounds great. Take care of yourself. Thank you. We'll see y'all tomorrow. Bye-bye.